son is helping me.
So
They can't see my beautiful Mother's Day flowers. Move them to the side. Is that too much glare?
I think so.
Maybe I move here, yeah? Let me move here. What do you think?
I've used the video. Let me mute the video. I face that way. I think it's better that way.
Okay, the computer faces that way. Okay, let me see. Let me just move so because there's a lot of glare with these windows. Oh yeah. What's that beeping sound? See, it needs to be more like this. Need more books, or maybe. How's that? Is that better? Is that okay, you guys? Yeah?
Yes.
Yeah, I think that's
Yes.
better. Bring
Ito
my
Sarah.
flowers. I just have to show you my beautiful Mother's Day flowers, okay? After all, if we're doing this from home, we gotta look at these. Woo! I hope you guys did something that's nice for your moms. Right. Okay, enough of frivolity, whatever. All right. Okay. You can all hear me. All 4 of you. Or is there more? Oh no, there's more. There's a lot more. Okay. Whoa, there's lots and lots more. All right, very good. You're all very quiet. Though. You're muted everything. All right, can you see my screen?
Yes.
Yes, okay. So Aisha, I can start?
Yeah.
Yes.
Okay, let's start. This won't be a long lecture. It's a fairly straightforward topic. Also a topic that's not very common in our country, but I think it's important to know. And I think certainly as diseases we start to see, particularly in the urban centers, it's obviously can be a deadly problem. So I think that's another important reason to talk about. Okay, interesting. Oh, my slides won't change. Oh, there. Okay, I fixed it. The arrows. Let's start off. So LGIB or LGI is lower GIB. So we're talking about lower GIB. Okay. So first and foremost, it says I'm muted. Am I muted? You can hear me, right? I do hope I'm not talking to myself. No one has their picture. At least you guys should have your pictures so I can see you there. No one has their pictures. That is a better, yeah. Antonio. Antonio. I think you can hear me, of course. Oh yeah. I'm press Alt. Alt. Where's Alt? Alt.
Now you're unmuted.
Okay. All right. All right. Are we good? All right. Aisha, are you there? Please somebody give me something. I'm a very interactive participant. That's very good. Okay. LGIB, lower GI bleeding. What is it? I guess I can't bug you on this, can I? I just have to do all the talking. All right. So basically, any bleeding that is the ligament of Treitz. Hopefully, you remember your anatomy. Ligament of Treitz is where? Right between the 4th part of the duodenum as it becomes a duodenum, right? Right as it comes sort of retroperitoneal and comes out to look like this. Many of you have been in an X-lap. Now, this incidence rate of about 20 and a half people, I can do a half a person, but anyways, 20 people, let's say roughly, per 100,000 is fairly common. But this is an American, North American, let's say European number. The incidence is much lower. But it exists. Yeah, it definitely exists. Tends to be more in men. Yeah, even here, the ones I've seen to be in men. Now, it also increases with age. Mainly, once again, that's reflective of the main causes, which we tend to see more commonly in a North American setting. But because it's in the ligament of trite, it means it could be either small bowel or colon. More commonly, it's the colon by far. But remember, if you can't find a reason in the colon, lower GI bleeds also can come from the small bowel. And I'll share with you a little bit later a case we had recently that was a small bowel. In general, this incidence that they're talking about here, or I'm talking about here, of 20 out of 100,000, is really reflective of the two commonest causes in a non-Kenyan setting. Yeah, and the reason I'm talking about the non-Kenyan setting is because of the fact that that's where we get most of the lower GI bleeds, and here locally we get some diverticulosis. But to be honest with you, personally, I haven't seen even one GI bleed from diverticulosis. Angiodysplasia is also, I have seen a few patients with it when I'm doing my colonoscopies, but I haven't seen much of it bleeding. So those are the two commonest causes globally. So how does it present? Well, I like to think of it in one of two ways, either acute, right? So sudden, lots of bleeding, bright red blood, or it can be more chronic, yeah, where you develop some blood that they see mainly in the bowel or the bowel movements, right? And they present more with anemia. In terms of treatment and approach, I'm going to focus more on acute, because I think chronic we kind of deal with already in other forms, in a more disease approach. This one I'm going to talk more about the acute because it's the one where patients can die. It's the one where it takes to respond more immediately. And I think it's the one that we don't deal with as much, and so people aren't as aware. So it can also present as melena is a lower GI bleed, right? So even if it comes from the upper GI tract, remember it's going to still have some gastric contents, bile, pancreatic contents that degrades, changes the hemoglobin so that the stool becomes black. So even melena can potentially be a lower GI bleed, could potentially be from the small bowel, right? And of course, hematochezia is the fancy word for blood in your stool. So typically, melena means bleeding from a more proximal source. Hematochezia tends in general to be more a colonic source. I've seen exceptions to those rules, but pretty well 99% of the time that follows those rules. Now, the other thing to keep in mind is you can get blood coming out the bottom end and it be actually from something above the ligament of Treitz, an upper GI bleed. Particularly because blood is extremely cathartic. Yeah, so if someone has a rapid enough bleed from an ulcer, excessive erosive gastritis from long-term NG tubes, suction, anything like that, a tumor that's popped into a big vessel and is bleeding, you can get blood getting into the colon, into the small bowel quick enough that a person just poops out blood. So we'll talk a little bit about one of the ways we can try to differentiate that. It's not very common, about 10% of the time, but you got to keep that in the back of your mind. Okay, so the most important thing to remember is the vast majority of times they actually stop on their own. So care is supportive, depending how much they're bleeding, whether they need to have blood or just iron replacement is enough. But the vast majority, thank goodness, because obviously we're going to talk about what are the ways to intervene, but they're all fairly invasive. They either require a surgical intervention or they require something of fairly high resource. So fortunately, most resolve spontaneously. Of course, once it resolves, there's always a risk it can come back. So then that's when you want to start to look for what might be the cause. Yeah. Now, when you start to get hemodynamic compromise, that's when you run into the issues of making some decisions about how to approach this. Now, hemodynamic compromise, what does that mean? Remember, a heart rate above 100, that's your heart responding to blood loss, trying to make up for the fact that your hemodynamic volume, your intravascular volume is lower than it should be, right? So that's early signs of shock. Any drop in your blood pressure. Now, if you're hypertensive, and you normally run 160, maybe a drop to 110, 120 suddenly is hypotension for you. So it's a bit relative, but in general, we use a convention of what? A systolic blood pressure of 100. So a systolic pressure less than 100, or an even more subtle early sign is what? Widened pulse pressure. Yeah, so you see somebody whose blood pressure looks normal, 130, but their diastolic is 50, or their diastolic is 45. That's not normal. Yeah, any diastolic below 60 becomes a bit worrisome and suspicious, especially if the systolic is above 100 and their diastolic is below. Either they have a diastolic heart failure, right, some comorbidity, or they have a widened pulse pressure and something's happening. And of course, once you have hemodynamic compromise, the approach to this bleed is much different. Yeah. So any hemorrhage that's significant requires you to be aggressive and start to resuscitate that person. Yeah. And only in terms of how they respond to the resuscitation. Do they keep bleeding? Do they bleed more? Do they respond by normalizing their blood pressure and their heart rate and their mental status? Then you'll basically know whether or not you can go down the route of looking at the therapy diagnostic options later, or whether or not you can go ahead and treat them more aggressively and do the things we're going to talk about here in a minute. The other thing to keep in mind is more and more and more, Aga Khan, lots of places are putting stents in coronary arteries these days, not doing bypass. You get a stent put in, you need to be double antiplatelet covered. So you have aspirin and Plavix. You have these antiplatelet agents, which are almost worse from a surgical bleeding point of view, than things like our traditional warfarin. So always when someone's coming in and they're bleeding, make sure you find out if they have any comorbidities, atrial fib, previous DVTs, PE, a stent of any sort where they're on an antiplatelet agent and or warfarin or some of the newer anticoagulants, right? We have anti-factor 10 anticoagulants these days. We have all direct thrombin inhibitors. We have a whole boatload of things out there. And of course, if you have an underlying intestinal disease, diverticulosis, angiodysplasia, maybe even just a small ulcer, maybe even a little bit of colitis from some entamoeba, and then you're on an anticoagulant, it's a bad combination. There are ways to deal with them. It, of course, requires, if it's an antiplatelet, you can give platelets, but platelets don't last long. And certainly in Kenya, it's very hard to get platelets, but that's an option. You can give FFP if it's warfarin or one of the direct. Warfarin. Or you have anybody with liver disease, okay, so their INR is up, you can give them vitamin K. Vitamin K can be given orally, can be given IM, can be given IV. It's not dangerous to give vitamin K IV, 10 milligrams. It's a good thing to keep in the back of your head. Lots of places have it. It's widely available. It's cheap. And sometimes if you're not even sure whether they have a coagulopathy or they have liver disease, you suspect it. It's not a bad thing to consider giving. Okay, so what are the causes? Of course, all these slides are blank to start off with, because in our usual way of doing it, I would prod you, poke you, wake you up, hopefully have you answer. But I guess you guys get it lucky these days, right? Because I can't ask you to answer. I suppose Aisha and I can start to plan a better way to have people answer, right? We can, isn't there some way, you know, you can put up your hand in this video thing? Anyways, we'll get more sophisticated in the future. So what are some of the causes? Well, the first two we've already mentioned, haven't we? Diverticulosis, angiodysplasia. Hopefully you're thinking yourselves through some of these causes. You've read it up a little bit on this already. Obviously, malignancies can do it, and colitis can do it, right? Inflammatory bowel disease, even colitis from NSAIDs, and certainly if you have any predisposition, a colitis can cause you to bleed. And then there's a few rarer things. Meckel's diverticulum classically presents one of two ways. It can perforate like an appendicitis, or the other way it can present is a bleed. because if it has gastrin-secreting mucosa in it, it can cause an ulcer, right? Which ulcers we know have two kinds of complications. They bleed or they perforate. And don't forget anorectal diseases, because people will come and they'll have bleeding, and sometimes it can be substantial. Usually anorectal diseases don't cause hemodynamic compromise. That's one thing that is not usually found. So if someone comes in hemodynamic compromise, I've yet to see it from an anorectal disease unless it happens to be a malignancy. Even that's pretty uncommon. So I think anybody in hemodynamic compromise, you want to think something higher up. But someone who comes in with significant bleeding, especially if it's caused anemia or just even a history of bleeding, you have to consider anal rectal diseases. The classic ones being what? Anal fissure and hemorrhoids, not fistula. Make sure you'll be able to differentiate those, right? There's anal fissure, hemorrhoids, and anal fistula. Right? Those are kind of the three big ones that you really come up against. It's good to be able to differentiate those three. All right. Let's talk a little bit about the two commonest causes, mainly because we don't see them as much, but I think it's good for you guys to know about it. Certainly, over the 10 years I've been here in Kenya, if you compare when I did colonoscopies 10 years ago compared to now, I see way more people with diverticular disease, way more Kenyan-born Kenyans who have not lived in America, who have not lived abroad, and have diverticulosis. Like I mentioned earlier, I haven't seen anyone who actually has bled from it, but that doesn't mean it isn't a possibility. So it is diverticulosis. So remember, diverticuli can be true, which means it's a full thickness, all 3 layers of the bowel. And these are the congenital ones you're born with, yeah? Those are the ones that you find higher up in the duodenum and places like that. But the ones you tend to find in the colon are false diverticuli, right? Or basically a result of the mucosa and submucosa sneaking through an area of the bowel that is weakened by usually where the vasa recta or the blood supply penetrates into the colon to supply the inner layers. There's also some theory that when a fecal lift gets there, you can also cause some trauma and blockage, kind of the same sort of pathophysiology we think it happens with appendicitis. That tends to give you perforation more than bleeding, but it still can give you bleeding. The incidence, meaning how often diverticuli bleed, the incidence refers not to how often they bleed, but rather to how common it is. And you can see up to 48%. So in a European or North American population, our epidemiology would suggest that when you're over 80, 1 in 2 people have diverticulosis. So in the North American context and the European context, extremely common. So you can imagine if 1 in 2 people, and even up to 10% can have bleeding, that's a significant number of people. Okay, so how do we treat it? Well, the best thing, the most common thing about diverticulosis as the cause of bleeding is the most of the time it is spontaneously resolves. 90% of the time, diverticular bleeding spontaneously resolves. But when it doesn't, it's surgery, because we know it's a structural problem. The difficulty becomes in localizing it. Now, fortunately, most of the time, diverticular disease is on the left side. So it tends to be, we can often get away with a segmental bowel resection, but we aren't always that fortunate. So this is when now we have to make a decision. So you have a patient, they're actively bleeding, they're tachycardic, say widened pulse pressure. You're in an institution where you can get them some blood, all right, in a fairly quick time frame or reasonable time frame. Or if not, you can give them fluid and the bleeding slows down. Then you can consider some investigations too. You can decide where exactly is this diverticuli, or is it a diverticuli? Maybe if you're fortunate and they come with a colonoscopy report they had 2 years ago that shows they have diverticulosis, then you can say, you know what, there's a good chance that this is what's causing the bleeding. We're going to talk in detail a bit more about the diagnostics you can use for lower GI bleeding. But if you're able, the patient is responding to your treatment or the bleeding is slowing down, that's when you're going to consider either endoscopy, which is colonoscopy, or angiography. Either angiography, where you put contrast directly into a vessel and take x-rays, or nowadays what we use more and more often, which is CT angiography. There is also the other option, which is not so commonly used. It's available at Aga Khan, but it's very expensive, and that is nuclear medicine scanning. That's another option just to know about. So the other thing to consider is a patient who has diverticular disease and who spontaneously stops and their blood pressure remains stable or becomes stabilized with some fluid or 1 unit of blood. They have maybe some anemia at 10 or 11, you give them some iron and they come back 2 weeks later and they're bleeding again. And then a month later, they're bleeding again. 6 months from now, they're bleeding again. At some point, that's a person who also needs a surgical intervention. If they don't respond, you're not able to do any of these interventions, then you need to go to surgery. And we'll talk a little bit more about that later and review it. But basically, sometimes when a person is bleeding actively enough, they're hemodynamically compromised with or without blood, preferably with, if you could, because even if you stop the bleeding by surgery, you still need to be able to replace blood that's been lost. Because if you've lost enough that you're hemodynamically compromised, your bone marrow doesn't work that well that quickly. If you're young or you're otherwise healthy, sometimes you can withstand losing 1 or 2 liters of your blood volume. But if you're elderly, you have any other underlying medical issues, losing that much blood and not getting it replaced in a sudden event, right? We know a lot of people walking around in Kenya with hemoglobins of 4 and 5. Yeah, but that happened over weeks or months. But if you have a hemoglobin of 12 or 14 and you go down to 4 in the space of hours or a day, that's a very different situation. So sometimes we have to go in, we have to operate and take out either part of the colon that we can see with the diverticuli, where we can, sometimes what we do is we actually sort of clamp off the colon and see, does it continue to blow up and get more and more blood? So that's where it's bleeding. So we do know what that's the part of the colon to remove. Or sometimes if they're really in bad shape and we just need to do it quickly and get out of dodge, as we say in English sometimes, and then we even have to do a subtotal or total colectomy to save life. So these are some of the decisions as surgeons we have to make. Okay, quickly going through angiodysplasia because that's also not very common. It's a type of AV malformation found in the wall of the colon. You can either acquire it later on in life. That's why it's more common in the elderly. It's often multiple. It can just bleed on its own. Yeah, it doesn't have to have any particular reason. Once again, it tends to spontaneously stop. And certainly most of the time, oh, Martin, you have a question. Oh, this is very good. You guys can raise your hand. Now what do I do? Now that you've raised your hand. Did you mean to raise your hand, Martin, Maina? Okay. I don't hear any voices, which is a good thing. It means I'm sane, right? Okay, I feel like I'm amusing myself here, you guys. I can't hear anything. Anyways, okay, I don't hear anything. I don't see anything, so we'll get to that. Aisha, feel free to phone me on my phone. If, okay, there's some orange chatting. You guys are chatting. Chat, 10 people are chatting. All right, anyways, I'm gonna keep going. And Aisha, feel free to text me on my phone if I should be doing something different, or call me if I should be answering something or doing something differently than I'm doing, okay? All right, where were we? Oh yeah, excuse me. Sorry, oh, don't worry, I'm COVID negative. Actually, I have no idea, but I'm pretty sure I am. Aisha, you have the ability to unmute any of us. Oh, okay, but then I just have to find you. So Martin, Martin's asking a question, eh? Oh, I just, let me find Martin. Of course, it's not in alphabetical order here. And there's only 65 of you. That's okay, let me find Martin here. You know, it'd also be really nice if you guys put pictures, because then I can start doing the names. I had muted somebody. I don't know who I had muted. Martin, I don't see you on here. Sorry about that, man. Ken Marvel. Now this is now when you should what names you put up there, isn't it? Martin, Antonio Mwangi, that's close but not. Excuse me, I've unmuted. Oh, I think it was not you. I unmuted somebody and they're oh, there you are, Martin. There you are. I found you. Unmute. Okay, Martin, are you on? Yeah. Unmute audio. Can you hear me? I'm trying to unmute you, Martin. Oh, it worked. Okay, Martin, ask your question. I unmuted you. Hello, Martin. Can you hear me? Martin, I've unmuted you. Okay, have you refused now to ask your question? You held up your hand by mistake, is that it? Okay, I'm going to mute you again so we can continue on. Yeah, I've just muted you again. Okay, and hopefully hopefully everyone's muted again. But anyways, okay. So now here's a picture. So angiodysplasia by far and away is most common as a bleeding problem when people are on an antiplatelet drug. Okay, it's a very common thing to find because it does bleed on its own spontaneously, but in particular, it'll bleed when you're on an antiplatelet. This is what it looks like classically, colonoscopically. It often has a central feeding vessel, which isn't always visible, but is the one that tends to be the cause. Okay. Yeah, thanks, Aisha. You muted everybody. Thank you. Good. All right. So now, occult hemorrhage. All right. So occult really is kind of a bad term actually, because basically what it means is we don't find a tumor, we don't find a colitis, we don't find angiodysplasia or diverticulosis. We don't know what the bleeding is from. Most of the time, in reality, it's from the small bowel. Simply because the small bowel, unless you have fancy things like endoscopic capsules, unless you have a CT scan with oral contrast and a really good radiologist who times it well, it's hard. The small bowel is smaller luminally. It is much, much bigger than the colon, the stomach, or anything else in terms of length. Things can hide in the small bowel. So most of the time, it's not so much occult as in the sense of something that we don't find the cause to, as it mainly being something in the small bowel. But there are some patients that even in a high resource setting where you have capsule endoscopy and really good upper GI series with contrast, you just can't find the reason. The patient I dealt with recently actually had this history of bleeding for like 2, 3, 4 years. They come in, they bleed, they get blood, they would get spontaneously improve, it would keep continuing, and he was young, in his 20s. So finally, he wound up going to the OR. We took him to the OR and did an X-lab. And what we found was he had multiple GIST tumors, small ones though, interestingly. Small ones, multiple ones in the duodenum and the small bowel, the jejunum, that were causing his problem. And because they were small enough and they were just on the luminal side of the bowel, they weren't picked up by any endoscopy. And second of all, they weren't even picked up well by a CT scan because they were not that big. So usually you can find it, but not always. Okay, this is the one where you would want to definitely look at doing CTs and endoscopies to try and figure it out. All right. If you don't have a cause, sometimes you can do what they call provocative diagnostic angiography. It's not done very commonly, but where basically, so we know what angiograms are, right? And we're not talking CT angiogram, we're talking about the traditional angiogram, where you put a sheath, we call it, which is very similar to what the dialysis catheter looks like, in your femoral artery traditionally. And then you can pass, so it's big, it's a big hose that goes in your artery, and your artery is big enough, it can handle that. And then you can pass catheters up it. Now, initially what you do is you put contrast in through that catheter, and obviously, you know, blood flows through your body quickly. And the idea is that you then begin to see a blush somewhere. And that blush is obviously bleeding outside a vessel. And you shouldn't bleed outside a vessel, should you? So this is one way of finding hemorrhage. And these are some of the fancy ways when you have bleeding that keeps happening and you know where it comes from. You can try to evoke it by using a heparin or a thrombolytic. That's something like TPA, a plasminogen activator that breaks down clot. Or sometimes even where you put it in and you go into the operating room, then shoot the contrast, look for it, and then you're ready to operate. Or even sometimes what I've seen done is you put the catheter in, you find the blush, then you leave the catheter in so that when we go into the operating room, we can see where the catheter is going in the terms of the small bowel or the colon, and note that that's the part of the bowel that we should remove. So these are all just different ways when it gets really tricky to figure out what's going on, because all the common things have been ruled out. So now, initial assessment of an acute, active, ongoing bleed. First and foremost, your ABCs. Give the person oxygen, right? Really the job of blood is to carry oxygen to your tissues. If you don't have as much blood, you might as well, any blood you have, any hemoglobin hanging out, fill it with oxygen. Put on oxygen. Start large bore IVs. If you don't have blood yet, but you've taken your cross match, you've taken your type in screen, you've talked to the family for donors, you've talked to the family if you're in a small location to drive to the bigger center to bring blood, or however it is your system works, yeah, blood is going to be needed. Yeah? You can draw hemoglobin, not because it's going to help you now in the sense of how much blood you'll need, but we know a lot of people in Kenya have chronic anemia, especially if you're working in a smaller place in the village. Yeah, there's still hookworm, there's still malaria, and there's still all kinds of other reasons. So it's nice to know if they were anemic to begin with, yeah, and now they're bleeding. It's going to be a bad situation if you don't get blood. So the initial assessment is always going to be establish an IV axis. IV fluids, of course, until you get red blood cells, are going to be your isotonic, your Ringer's lactate, your normal saline, right? Remember to ask about any coagulopathies. Do they have any liver disease? Remember, kidney failure can cause a coagulopathy. I hope you know that. Platelets don't work well in a person who has significant renal deficiency or renal failure. And one trick, it's not really a trick, one approach, I call it, you know, and it's not surgical, I call it a trick, but that's, anyways. When you have a person who's in renal failure and you think the ability of platelets to stick is being compromised because of the renal failure, you can give them desmopressin. Yeah, I'll let you look up the dose of that, because I always have to look up the dose of that because it's not something you use all the time. That's something I use in the ICU. Yeah, so a person in renal failure who's actively bleeding, you can give desmopressin and make the platelets sticky. Anybody who has von Willebrand's, you can use desmopressin. Remember, if you have hemophilia, you can also have bleeding issues. So think about coagulopathies, either acquired through meds or congenital. Now, the NG tube is, remember we talked earlier about the upper GI bleed can give you a lower GI bleed, or the person doesn't necessarily vomit, they poop it out. So always put in an NG tube to look to see if there's any blood in the stomach. If there's blood in the stomach, then your lower GI bleed may actually be caused from an issue in the upper. So of course, you're going to change how you approach it. You're going to include upper endoscopy. You're going to make sure if you do a CT angio, you include the upper abdomen, different things like that. Someone's writing on the screen. Anyways, remember, it's effective in picking up only pre-pyloric hemorrhage. All right, so it's good for stomach and above. So if you have a duodenal ulcer, you may or may not pick it up, unless you happen to get fortunate and the NG tube went into the duodenum. Okay. All right, so we have kind of ways to look at this. You can divide them into basically, is this just a little bit of blood? You know, they're just, you know, droplets coming out, or is it massive? They're filling the bedpan, they're filling the toilet, and it's slowing down and stopping, or it's ongoing. If it's major, they're pooping out blood and blood alone, and it's ongoing, and they're hemodynamic compromised. If you don't have angiography, which most places, unless you're at KNH and the suite's working, because there are people who do angiography at KNH, yeah. Definitely Dr. Chacha and other guys that are there, or Aga Khan, and you can get them to come in and do it, okay? If you can get angiography to help you see where the lesion is, and potentially, the advantage of angiography potentially is to intervene, right? We'll talk about how you can do that in a minute, or surgery. If it's major or minor, then this is when you're going to start thinking about looking for the source first, because most of the time, remember, it just involves self-limited, and you may not need to do anything, but in case it doesn't and it becomes major ongoing, you want to know what it's caused from. So if you need to do surgery, you know where to go. So those are the ones when you start considering, can I colonoscope the person, or do they need something fancier like angiography? And in our setting, pretty well, we use CT angiography. Obviously, colonoscopy, if there's ongoing active bleeding, you can't see much. You have to give them sedation. So it depends on what resources. Do you have an OR available, an anesthetist to help you? Does the person already have blood? Do you have an endoscopist who's good at what they're doing and can try and see something? Or do you have a CT available? So whether you choose one or the other depends on how much the person is bleeding, how hemodynamically compromised they are, and what you have available. Don't forget to do a digital rectal exam. Very embarrassing to start ordering fancy, expensive tests, CT angios, or calling in your anesthetist quickly to do a colonoscopy to find if you'd stuck your finger in there, you would have felt the mass, or you would have saw the bleeding hemorrhoid, right? Now, so make sure you always have a quick look. You can do a proctosigmoidoscopy without any sedation, right? Obviously, it's not very comfortable for the patient. Nobody likes it, but hey, nobody likes a lot of the things we do, but we're doing it to help them, right? So those things can be done quickly and easily. They can be done in a casualty department, in a clinic, even on the hospital ward. So make sure you do a digital rectal exam, and if need be, there's any concern, a proctosigmoidoscopy that can be done without any sedation. Now, the main advantage to colonoscopy and angiography is you can do a therapeutic intervention. Nuclear scanning, of course, is pure diagnostic, and in Kenya would be very hard to get and very expensive. The advantage, and why I mention it, is first of all, you should know about it. Second of all, it's more sensitive. Nuclear scanning requires a lower level of bleeding, and it can still be detected. So that's why it still sits in the armamentarium of what we do, because if it's bleeding at a slow rate, you might not see it in colonoscopy or angiography. You could pick it up in nuclear scan, but it doesn't help you. You can't do anything therapeutic. It's not very specific about the location. It can tell left versus right colon, colon versus small bowel, but even then sometimes it's tricky because in your body, these things often overlap, and the nuclear scanning can't necessarily differentiate. But it's highly sensitive, and that's where its role sits. Okay. All right, so I already sort of spoke about it. The two different techniques are technetium sulfur colloid scans, or 99 per technique tagged red cells. It's very, very sensitive, but specificity is low. In general, it can detect as low as 0.1 mils per minute. That's a pretty low rate. As opposed, so if you have a positive blush within the first couple of minutes, then it's highly predictive of needing of a positive angiogram or even a need for surgery. Angiograms are useful, but you see, you need a much higher rate of bleeding, 1 mil per minute. Sometimes some people say as low as 0.5. So it's not a high yield, all right? It's usually done when there's a major bleed, but the person is maintaining blood pressure, so you don't need to rush to the OR. And in our setting, we tend to do CT angios. The disadvantage of CT angio is we can't do any intervention. Yeah? It's very specific. It also can pick up bleeding even at a lower rate than traditional angiography, but you can't do any intervention other than a surgical one, or then maybe trying to do a colonoscopy. But with angiography, what you can do is once you find the bleeding source, you can infuse some vasopressin, which we know is a vasoconstrictor. Of course, downside is it constricts other blood vessels. So if you have patients with coronary artery disease or peripheral vascular disease, you can get some side effects you have to be aware of. You can also embolize. That works particularly well with small bowel because it's got so much collaterals, and the stomach, it works great because the stomach has great collaterals. It's a little bit more tricky in the colon because the collaterals are poorer. And as we know, with age, collaterals get even worse. With age, a good percentage of people don't even have an IMA anymore. The IMA clogs off. And that means your whole colon relies on the distal rectal vessels that come off of the internal iliacs, right? Or mainly the SMA. So you can imagine the whole colon relies on just the SMA. So the blood supply is a bit tenuous. So in older people, sometimes embolizing the colon, you actually kind of wind up sometimes down the road going in and operating because the colon, that part of the colon. Of course, like anything, it's invasive, so it has some complications. You can thrombose the artery where the catheter was. You can get renal toxicity from the dye. And the reason for this is the renal toxicity from the dye is a much higher dye load than you get with CT angio or with other forms of contrast used radiographically. Colonoscopy, you need to be a fairly stable patient because you need to have some sedation, right? You need to give them ability to give them anesthetics. And it's really hard to locate. Colonoscopy and actively bleeding, we often try. Usually, sometimes what will happen if we know a patient's likely going to need surgery, we take them to the operating room. And if we really have no idea where they're bleeding from, we may, if the person has a blood pressure, we have a bit of time, we have blood going, we seem to be responding, we can try with colonoscopy first to see whether or not we see where they're bleeding from. Because we don't want to take out their whole colon if we don't have to. And then if we can't see it, which is often the case, then we can just proceed with colonoscopy surgery because we're already there. So the biggest downside with colonoscopy is the fact that you can't see very well, and unless it's a fairly specific isolated location with a good suction, you really have a hard time seeing. The advantages, though, is if you do see it, there's things that we can do, and the things that we can do are we can zap it with heat. Yeah, we can coagulate it. Yeah, we know we have coagulation. We can inject it. The same port you pass the biopsy catheter, you can pass a needle. Yeah, so it's on the end of the long tube, it goes in, and then once you're outside the colonoscope, you can make the needle come out. You can inject epinephrine, okay, which can stop the bleeding. That's classically done in upper GI bleeds with ulcers, and you can even use endoscopically applied clips. So the advantage of the colonoscopy and why people try it is not just knowing where you're bleeding from, but if the bleeding does slow down enough, you can see where the person is bleeding from, then you can go ahead and do some therapeutic things. Coagulation is easily available in Kenya, injections easily available, even clips not as available but are available as well. Okay, operative therapy. Of course, it's going to be the one of last resort. No one wants to operate unless you have to. And the biggest reason is there's nothing worse than taking out someone's whole colon, for example. They were bleeding actively, even though you're giving them blood or you didn't have blood available, they were crumping with their blood pressure, they were going into severe shock. You thought, you know what, if I don't do something, they're going to die. You take out their whole colon, you give them an ileostomy, because when they're that sick, you're not going to put them back together. And then you take them to a recovery room. The next day you come to see them and their ostomy bag's full of blood. Meaning either they have more than one bleeding source or you didn't get the right bleeding source and you've just done a total colectomy. People can live with total colectomies, but obviously it's not very nice. Mainly because the colon is what makes liquid enteric contents become stool. So if you take even in a young person, their small bowel, and hook it up to their rectum, you tend to have sort of diarrhea for the rest of your life. You can get better, you can reduce it, your small bowel can adjust, but it's still not a very nice thing. So operative therapy, we try our best to do when really the person is not stopping their bleeding, not responding. Any of the therapeutic interventions we might have available, like angiographic or colonoscopy, either haven't worked or they're not available. So then we just have to operate. I would really try and encourage anyone to try and get blood and stabilize someone first, because most of the time it stops on its own is the first reason. Second of all is even if you operate, if you don't have blood and they're that sick, even if you operate and remove it, you can still lose the person. Some of the tricks we do when we're in the operating room is we can, I mentioned earlier, clamp off different parts and see where we think it's bleeding. Sometimes we even have to do an on-table endoscopy to try and help us as well. So those are all different things that we can do. If it can't be found, the source, then sometimes we just have to go ahead and do a subtotal colectomy to save life, and then go ahead and give them an ileostomy and come back at another day and put them back together. So in summary, what are our take-home points from all of this? First and foremost, think about if someone comes in bleeding, is it upper or is it lower? Yeah, because that's going to change your approach. Upper bleeding, we haven't talked about, but is your classic peptic ulcer disease, which of course in the era of PPIs we don't see as much, but in general those are endoscopically controlled, and this of course they are due to a cancer which requires surgery. Whereas below, they're vastly much more likely to spontaneously stop on their own, even if you just support them with fluid or blood. So think about upper versus lower. Don't forget to consider anorectal diseases by doing a digital rectal exam. Don't forget to put an NG tube in, even if it's bright red blood, to make sure it's not coming from the stomach. Then the next step is this patient hemodynamically stable? Is this a major bleed or a minor bleed? If it's a major bleed and you're in a small place and they have the ability to get to Eldoret or Kisumu or Nairobi, that's what you need to do. Because they need to be considered for CT angio. They need to be considered for angiography if it's available. They need to be considered for surgery. They need to be considered for colonoscopy and some of those interventions that are found in only more specialized places, injecting epinephrine or clipping or coagulating. So next step, once you think about is it upper versus lower and what it might be, do they have a history of liver disease? So it's a coagulopathy. They're taking platelet therapy. Therefore they may have a small lesion, they may have a tumor, but there's a platelet issue. Do they have a history of a colonoscopy that showed they had angiodysplasia or diverticulosis? They have a history of IBD, yeah? So first and foremost, is it upper, is it lower? Do we know what might be the cause? And then are they actively, majorly bleeding or minor? And then of course you have to, after you've considered those and you've got some idea what you're dealing with, and that's when you have to think, okay, what do I have available to me so that I can try and diagnose this? And do I have a surgeon available so that if they keep bleeding, that person can come and operate? Okay, let us stop there. Woo, 9:54. So I kept it within the hour. So now we can try and answer any questions if anyone has any. I can do my best to unmute, or maybe even Aisha. You might even unmute for me. Or you can just unmute everybody. Okay, was there a question there? I thought I heard someone asking. I couldn't hear what they said. You know, the other option you guys can do is you can text me, yeah? Don't you have my number? Yes, no, maybe? That might be another way to do it. I don't know. What do you guys think? It's quite surreal, you know, I'm talking about the computer. I have a picture of myself and that's it. So that's another option. Good text, or I don't know, Aisha, what do you think? Just trying to think outside the box. You could even make like a WhatsApp group, you know, or something. And oh, I hear a voice. Well, I'm willing to sit here for a little bit longer, no problem.
Hi, Professor.
Hi. Who's talking? Aisha, is that you?
Yeah, it's Aisha. I've given participants the ability to unmute themselves, and I think the best way to do this is for each participant to raise their hand and for you to choose one participant at a time.
Okay, sounds good. All right, don't all raise your hands at once. You know, I have a very nice garden. I think the next time I might try doing it in the garden. All right, you guys, 3 minutes to 10 o'clock. I'll give you 3 minutes. How's that? Since we're supposed to do 9 to 10, right? It's supposed to be a 1 hour. No questions. It is a pretty straightforward topic. There's no doubt about that. It's fairly straightforward, so that's a good thing. Hey guys, 1 more minute, 9:59. Is everyone happy? You are, then Aisha, shall we? So Aisha, what do you think? Everyone's good? You know, if you have a question or a concern, you can always email me. I'm sure you can share, you guys probably have a WhatsApp group or something, you can share my email address. So feel free. Oh, here's a question from Otieno. What's the role of balloon tamponade? Okay, balloon tamponade. So I'm not 100% sure exactly which kind of balloon tamponade you're referring to. Are you talking about where there's trauma? You know, a big tamponade in the aorta, and there's balloons we can blow up and thereby differentially cause blood flow to go to the upper body as opposed to the lower body. Or there's the kind of balloon tamponade where we take Foley to compress the bleeds. Yeah, so like for example, if you have a big bleeder in the liver, we stick Foley catheters in and blow it up. Or for example, you're probably thinking of the upper GI where you have esophageal varices, and you use the Blake-Stanksmore tube and you tamponade. Because of the kind of causes in the lower GI tract, you know, colitis, which is going to be in a big location, diverticuli, which is now the blood vessel is in the wall, angiodysplasia, okay, you could potentially, you know, compress it to some degree, but it hasn't played a role. I guess that's the simple answer, right? The simple answer is tamponade in the lower GI tract has not played a role. I think it's just the kind of causes and we don't really have any sort of things that would be put in and be able to inflate. You know, it's easy to stick something down the esophagus, but I think it just doesn't play a role. I hope that answers your question. I don't know of any instruments that we use in the lower. Obviously, if you went in and had a colonoscope and had an angiodysplasia, it's just as easy to inject it as it is to try and push on it. Okay, we have a question here. In which cases do you avoid some of these diagnostic procedures? What is the risk of causing perforation with the diagnostic procedure? So that's a good question. So in other words, what are the complications of these diagnostic procedures? Good question. All right, first, colonoscopy. The complications, excuse me, for colonoscopy are the same. Sorry, I need my morning coffee, don't I? Colonoscopy, the risk or complications are the same as you would if you're removing a polyp or doing anything else. In other words, if you're zapping, you're coagulating the wall of the colon to stop a bleed, a diverticular bleed, of course you could hold it too long, burn too much, and cause a perforation for sure. So in other words, just doing a colonoscopy has a risk of perforation because you can go around a corner, you can tent, you can cause shearing injury. But anytime you're doing anything interventional with a colonoscopy, whether it's injecting with epinephrine because you're causing ischemia, whether your risk of perforation goes up. But remember, you're trying to stop bleeding, and bleeding is a bad thing. So it takes judgment. It's definitely a risk. You would tell the patient that's a risk, but the other option is to leave them to keep bleeding. If it does perforate, then you treat them as a perforation, which if they're prepped, obviously if they were well enough to get a prep first, then you don't even have to operate. You just treat them with some antibiotics. If they weren't prepped, then you of course would have to consider whether or not they get sick from the perforation. If they get peritonitis and get sick, you have to operate. So colonoscopy, the biggest risk is perforation, but it's once again a balance. If they're bleeding, you need to do something. Angiography, you can cause, if you embolize, you can cause the downstream organ to become ischemic and die. You can cause injury to the artery you're passing through. But once again, you're actively bleeding. Nuclear medicine, it's obviously can become radioactive. Yeah. CT angio has probably the lowest incidence of complications. You can get some kidney dysfunction with the contrast, but it also is the least helpful because there's nothing intervention you can do with it. CT angio, it's totally diagnostic. So hopefully that answers your question. Remember, as doctors, that's why the early doctors always said, do no harm, because everything we do, and even internists, even COs, when you give out a pill or a drug, even a drug, a pill, can cause a side effect. If you're allergic, a person can die. Children given aspirins get Rye syndrome. Yeah, so just remember that everything we do has a risk, so it's always about risk and benefit. Now, let's see, there's some other questions coming in here. I may not answer them in order, so forgive me for that. Do we have nutritional value in improving treatment outcome for patients with lower GI bleeding? Okay, so thinking about the causes we talked about, obviously any of those diseases, if you keep them under control, if they're better controlled, like a person with an inflammatory bowel disease and ulcerative colitis, if they're better controlled, they're going to bleed less. Diverticulosis is thought to be related to a low fiber diet. Once you have diverticulosis, there's not much we can do about the ones you have, but improving fiber in your diet is thought to reduce your chance of getting new ones. There's no nutritional prevention for angiodysplasia that I know of, or Meckel's diverticulum, or some of those other ones. Obviously, cancers, we know that there are some risk factors in diet related to cancers. Yeah, a low fiber, high meat, low vegetable diet is at a higher risk. So yeah, so there are some nutritional things, but they're not directly related. And once you're already bleeding, then it's too late. But if you get it under control or they stop, then you can do that. All right, now let's look at a few others here. Humphrey, how does kidney failure cause a coagulopathy? Okay, it's platelets. When you have a high creatinine, remember, kidneys do what? They get rid of toxins or bad things or byproducts of what we have in our body. Yeah. So what is really the issue is not the high creatinine. Creatinine is a marker of how well you can urinate. That's all creatinine is. High creatinine is not a bad thing in of itself, if you know what I mean. Okay, so an elevated creatinine is a marker your kidney is not working. But the effect of your kidney not working is uremia. Okay, so that's why when you're looking at kidneys, whether they're working or not, you should measure the urea and the creatinine, not one or the other. Yeah, because if your urea goes up, yeah, you get uremic, and uremia produces all kinds of symptoms. You can even get abdominal pain. People, I've been consulted on patients with acute abdominal pain, and it actually turns out they're in acute kidney failure. They don't have necessarily a surgical issue. They have acute abdominal pain from their uremia. Their kidney is not clearing the toxins. So one of the effects is your platelets stop working. Remember, when you cut yourself, what's one of the first things that happen? Your platelets stick together. Now, if you want me to get biochemical about it, now you're talking over my head. Basically, I'm giving you the sweet and dirty version. And if you want to know more of the molecular biochemical side, please look it up. But basically, when you have kidney failure, when you're uremic, your uremia, when your urea is high, your kidneys are truly not functioning. So you can have an elevated creatinine, yeah, for a short period of time because you're hypovolemic, but you recover, so your kidneys just got a little bump, but you're truly in failure where your urea is high, your creatinine is high, your platelets don't stick. So you bleed, your platelets are supposed to come, stop that clot, or start to make that clot by making your platelets sticky. Yeah, and desmopressin works because it makes your platelets sticky again. Hope that answers for you, Humphrey. Let me see from Steve. What is bowel prep for colonoscopy? Okay, good question. Bowel prep involves cleaning out the whole bowel of stool. Because if your colon is full of stool, we're not going to be able to see very much. And it usually involves what we call the osmotic laxatives. Those are the guys who pull fluid into the bowel, and so that you get a diarrhea. And the classic one is polyethylene glycol. It's not absorbed into your body, and it acts by pure osmosis. You drink it, it's a large molecular weight chemical, pulls water into your bowel, and you have diarrhea and poop out all your poop. The problem with bowel preps is they take a bit of time. You got to drink 2, 3, 4 liters, and you got to poop out all this stuff. So usually the problem becomes in acute GI bleeds is a person, unless it's a minor bleed or they stop bleeding, that you don't get a chance to do a bowel prep. The one advantage, if they slow the bleeding down, is that, remember we mentioned blood is a cathartic in causing you to poop. So oftentimes if someone's been bleeding for a day or so, they're already cleaned out. It's just now a matter of whether the bleeding is slowed down enough that you can actually see anything. So bowel prep involves either mag citrate or polyethylene glycol. And sometimes people give along with that a Docalax because it's a stimulant type of laxative. So it's basically giving you a dose of heavy duty dynamite, also known as laxatives, to clean out the bowel so that you can actually see in the colon well. Good questions. All right, let me see if there's any others here that I hopefully haven't missed any. Oh, here's one about FAP. In FAP, which I hope we know about it, I hope you all know about it, familial adenomatosis polyposis. What is the risk of lower GI bleeding compared to colorectal cancer? Do you do colectomy in FAP that is bleeding? Okay, so FAP is, as you said, it's a congenital disorder. It causes polyps throughout the whole colon, like a carpet of polyps. In general, polyps don't cause massive bleeding. Colon cancers they can erode into a vessel and cause massive bleeding. But in general, polyps, they're on the list, but they really rarely cause any kind of significant GI bleeding. Of course, if they torse and become ischemic, they cause some bleeding. But usually polyps are asymptomatic, and if they bleed, they're going to bleed pretty minorly. They're small. even the amount of blood you're going to lose is not a lot. So we tend to operate on FAP and do total colectomies because all of those polyps just statistically increase your risk of getting colon cancer. Plus, the genetic disorder in the DNA of your cells in your colon inherently predisposes you to colon cancer. So a person with FAP who does not get a colectomy will have, if they don't die from something else, being run over by a dump truck, or I don't know, taking an overdose and suicide, or some other reason, if they don't die from another reason, in their lifetime, they will develop a colon cancer, and usually by the age of 50. So we take out their colon not because of bleeding, we take out their colon because of the colon cancer. So your question that polyps bleed more or bleed a lot, and they don't bleed very often at all. It's colon cancer, if anything, and even then colon cancer is not a common cause, but it certainly can cause it. Okay, so those are good questions. All right, let's see. Any other questions coming through? I don't see any others. Have I missed any? I'm going back through my WhatsApp here, but I don't see any. Anybody else? Are we good?
Hi, Professor.
Hi, Aisha.
Aisha. Yeah.
Mhm.
Braden has raised his hand, and
Oh,
there
okay.
may be some questions
Okay.
in private chat.
Oh, in private chat. You mean on my phone or here?
On your computer.
Oh, okay. I don't see that. Sorry, I didn't see a hand go up. Can you turn him on or something, maybe, Aisha? Because I don't see it here on my screen for some reason.
Hello, Professor.
Yeah, hi, Braden. How are you doing?
I'm fine, thank you, Professor. I wanted to
Good,
ask,
good. Tell me now.
does octreotide has any role in management of lower GI bleeding as it has a role in upper GI bleeding?
Yeah,
And
good
thank you very
question.
much for taking your time.
Yeah, no problem. The short answer would be no. It doesn't. It doesn't have a role. Even vasopressin, which we often can use in upper GI bleed as well, also doesn't have a role. I think that's mainly because the upper GI bleeds tend to have a lot of good collaterals. And so what happens is that actually makes them bleed more. And so by just causing vasoconstriction, we can control them. But because most of the bleeds in the colon are either in a very specific location, just kind of shutting down the vessels just doesn't seem to work. Octreotide, it just doesn't work in lower GI bleeds, so it doesn't have a role. It doesn't have a role. Even vasopressin infusions don't have a role. And I would use only either of those only if you thought or weren't sure where the location of the bleed was from. So if they're massively bleeding, they're really sick in the sense of they're in hemodynamic compromise, and you're not sure is it upper or lower, you could start them on some vasopressin or octreotide in that sense. But the minute you know it's lower, I'd stop it. It has no value. Good question. Well, I think there's another question just came through here. What's the quality of life after a total colectomy? Okay, good question. It is age dependent. It can be reasonable. It's changed. I think the best way to answer it is you'll never poop the same, for lack of a better way to say it. Your colon's main job is to reabsorb water. It's not necessarily a digestive. And I'm not an expert on the physiology of the colon, but in general, its main job is to reabsorb water and change what tends to be the soupy enteric contents that you see if you have an ileostomy or those sort of things into stool, the solid stool. So basically, you can imagine if you lose that, what happens is what's in the terminal ileum, when it hits the rectum, it only has the rectum. Remember, the rectum is 25 centimeters. It only has 25 centimeters to now, and really the rectum is a storage space. So what happens is you get diarrhea. And you know yourself, when you have diarrhea, your sphincter only works so well, right? You know, when you got diarrhea, you gotta like get to the toilet now. So what happens is people can have some degree of incontinence, they can have soilage, they can go to the bathroom instead of once a day or twice a day, 6, 7, 8, 9 times a day, But the good thing is that often with time, the small bowel adapts. It's amazing, our bodies. The small bowel can adapt and can increase its ability to reabsorb water. So with time, it can get to the point where it's manageable. In other words, it's not like it used to be where you went once a day, or you maybe even were constipated. Now you go 3 times a day, but there's some control, there's some predictability. There's also some nutritional things you can do. You can increase the fiber in your diet. You can watch for things that tend to go through the system quicker, so to speak. So sometimes nutritional changes can help you as well. Okay, that's a good question. So in other words, the bottom line is, if I'm going to save your life, or I'm going to cure you of a disease that could give you harm or kill you, yes, I'm going to give you a total colectomy. The downside is I'm going to make sure there's a good reason why I do it, because I'm going to change the quality of your life. I'm not going to make it so your life is not worth living, hopefully, but I am going to change the quality of your life. So once again, everything we do in medicine is a give and a take. One last comment I'll make about that is, the older the person, the poorer a total colectomy will be tolerated. So I will think long and hard about a person who's 65 or 70, especially a lady who's had 10 kids, because we know her sphincter is not going to be in good shape. I'm going to think even harder about why I'm doing this total colectomy than if the person's 30. Simply because at 30, your body's much more adaptable. You'll likely get over it. You'll likely get to a point where you can deal with it. It's tolerable. Your body's adapted much better than someone in their 60s. Once again, it's always a give and take. But certainly I'd do it to save someone's life in a heartbeat, because you can definitely live with a total colectomy. Good question. All right. Any other questions out there? I know we already did the sepsis one we did, and the colorectal cancer one we did. So I'll turn the slides into notes for you, and I will send them along to Aisha. Yeah. So, if you wanted, what we could do is next week at the same time, we could do for maybe like 30-45 minutes. If you're interested, we could do a case presentation. So I will bring a case, and then we could discuss it and discuss some of the diagnostic components, some of the, it's a little bit hard to kind of do the back and forth. That's why I keep it short. But I could do a presentation on a case and then kind of learn around the diagnostics, intervention, those kind of stuff. If you're interested, let Aisha know, and then Aisha's my person. She's my resource. She's my woman. So she will contact me. She's awesome. You guys better appreciate her. She does a lot of work. So if you're interested in that, we can do that next Wednesday. What's the date today? Today is the 13th, isn't it? Yeah, so next Wednesday, the 20th, 9 o'clock, if that works for you guys, for like 9 to 9:30, 9:45, depending on how many questions there are. I can present a case, and we can go through it and use that as a platform to learn some things about surgery, if you're interested. Okay, and I don't see any other questions coming through. Are we okay to end now? What do you think, Aisha?
There's one more question from
Oh, okay.
Isaac.
Right.
I believe he sent it via regular text.
Oh, okay. Sorry, I wasn't checking my regular. Oh, it didn't come through. I don't know who he sent it to. Does he have my right number? Is it? Oh, here's one from Charlotte on WhatsApp. Let me enter that. Well, Isaac, you either do it regular text, but it's not come through, so I don't know if you have the right number. Okay, so let me answer this one, and then Isaac, hopefully you'll send yours, or just unmute yourself, Isaac, and tell me your question. The subtotal colectomy, will the patient be put on colostomy bags, and for how long? Okay, good question. No, a subtotal colectomy, or even a total colectomy, you don't necessarily have to be on colostomy bags. You'll be rehooked to the rectum. So you'll do an ileorectal anastomosis. Now, having said that, Vast majority of patients who I do a total colectomy or subtotal colectomy, or most surgeons, I would think, who do it, are doing it for people who are bleeding a lot, or who are hemodynamically compromised. Even if we're giving them blood, they're in bad shape. So usually we would give them an ileostomy, because remember, in anastomosis, we don't want it to leak. The person's already in bad shape. The risk of leaking is high, and that makes people sick. So I would give them an ileostomy first off, but it would not be permanent. It would be a temporary ileostomy. And down the road, they make it through this bleed, they get their blood, they get sorted, they get healthy again. Yeah, 6 months, 3 months, whatever, down the road, I will put them back together by taking their ileum and hooking it to their rectum. So it's not permanent. So a total colectomy means removing the colon, but you still have a rectum and you still have a small bowel. So you can hook those two things up. Now, let me see if, okay, Isaac's question. Okay, intestines do have bacteria, it's true. When intestines are exposed, does it pose any challenge of sepsis? When they get into the blood, when a patient is anemic as a result of a reduced amount of white cells during last hemorrhage? Okay, good question. You're welcome, Charlotte. Yes, it has bacteria, but remember that not all bacteria are bad. And it's just, sure, I'm sure they get a bacteremia, but once again, the bacteremia doesn't necessarily mean it becomes pathogenic. Remember, infection is a combination of a patient, the situation they're in, the bacteria itself, and the environment. It's not just a bacteria shows up, that's instant infection. Yeah, no. I'm sure they probably get bacteremia, but doesn't mean they may get infected. And there isn't a risk of sepsis. Yeah, that's why you should wash your hands after you go to the toilet, because poop is basically bacteria. And you got it on your hands and you don't want to really spread it everywhere, right? But the vast majority of bacteria are good bacteria. Nothing wrong with them. As long as we stay healthy and you got the right kind of bacteria. Actually, not having bacteria is one of the main problems when you give people antibiotics inappropriately. You kill all their GI bacteria, and then you actually get diarrhea, actually get problems. Every person I put on antibiotics, I tell them eat yogurt so that they can get their lactobacillus and some good bacteria back in there. So the short answer, no, you will not get sepsis because you're intervening in the intestine. Yeah, you might get a bacteremia, but that's different from infection. Good question. I like that question, Isaac. All right, I think there was, well, thank you for calling it a bold move. Yeah, being I don't feel very technologically savvy very often, but I guess we're doing it okay today, huh? Well, it's nice to actually get the messages because I feel like you're out there. Otherwise, I'm talking to myself and my curtain and my mirror here. So next week, if we do it, you can meet my puppies, my doggies. You know, I'm an animal lover, eh? So I'll let you meet Bob and Larry, Ted and Jerry, and of course, you have Dobbins who's visiting. So we have 5 dogs, and they're crying in there because they can hear my voice, and they don't understand why they're not in here with me. Okay, there's another question. Whoa, thank you for all the thank yous. I appreciate the reinforcement because it's otherwise I'm feeling a bit weird talking to myself here. Okay, one last question. Oh no, that was Humphrey. I already got that question. How does kidney failure cause coagulopathy? Tour number. What's the tour number mean, Aisha? I'm not sure what that means, but that's okay. You can tell me. All right, so you'll let me know about next Wednesday ahead of time so I can prepare myself a bit. And if not, all the best, you guys. And hopefully we'll get to meet face-to-face sometime in the near future. All right, bye for now. I'm signing off. At least I'm going to try anyways. Oh, you know what? There's a Zoom chat thing. Hey. Oh, there's other questions on the Zoom chat. Oh my word. Who's crying in there? Is that you, Bob? Holy Max, there's all these questions here. Look at all these questions. Are you guys still there? What? Wait a minute now. Okay. Okay. Let me try and answer my questions. Okay, let me just make a note of some of these questions. Oh, yeah. Okay, let me just. So diff, leak versus fistula. Break bad news. Tattooing. Oops. Oh, I should have done everyone. Oh, I see how this. How do I do?
Hello, Professor.
Hi there, Aisha. I'm just seeing this chat thing now.
Yes, and I've seen only one question, and from Gabriella saying, how would we break bad news to such patients and their families?
Yeah, then there's also a question about how do you differentiate a leak from fistula. And then there's a question about tattooing. Yeah, so there's a few questions that didn't get answered. You want me to answer them now? Or we do it next week, or we're not going to meet next week, or what do you think, Aisha? You're muted yourself again now.
Some students are saying next week.
Yeah, I think so. I agree, Collins. Yeah. Yeah, that's good. I think we do, because it's been an hour and a half. What do you think? And now next week I'll know, I will know this chat thing. Isn't it? And there's even a whiteboard. I can try the whiteboard. All right. Okay. Mail.